Welcome to the Impact Education PayerTalkCE program entitled Understanding T2 Inflammation, Best Practices in Asthma Management. My name is Jeff Dunn. I am the President and CEO of Cooperative Benefits Group, a transparent pass-through PBM located in Salt Lake City, Utah, and I will be moderating today's session. This PayerTalkCE program is jointly provided by Partners for Advancing Clinical Education and Impact Education, LLC. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi, and we would very much like to thank them for their support of this program. At the conclusion of today's program, you will be able to complete an evaluation which must be submitted to receive credit. You will be able to click on a complete evaluation link in the navigation within the activity. And once you complete your evaluation, you must then click Claim Credit to download your certificate, or for the pharmacists who are joining us today, submit your credit to the CPE monitor. Today's learning objective is to assess payer care management initiatives and other opportunities to improve treatment access and overall quality of care based on current evidence from clinical trials and treatment guidelines. I am joined today by Dr. Andrew Peters and Dr. Michael Kobernick. And Dr. Peters, do you mind introducing yourself?
Absolutely, Jeff. Thank you very much for including me today. I'm Andrew Peters. I'm an allergist at Northwestern University in Chicago. I take care of patients with all severities of asthma, and my research interest focuses on chronic rhinosinusitis and comorbidities, so asthma is right in there. Thank you again.
Fantastic. And Dr. Kobernick, will you introduce yourself, please?
Hi, Michael Kobernick here, and I'm a senior medical director at Blue Cross of Michigan, and I've been here about 7 years, and I work on all things coverage related, as well as advising employers on strategies for managing healthcare benefits. Prior to that, I was an emergency physician for 30 years in the Detroit area and have amassed considerable clinical experience in the management of acute asthma rather than chronic.
Thank you both for being here and for introducing yourselves. I'm looking forward to this conversation. This will be great. So let's jump right into it. Dr. Peters, let me start with you. And the first question we have is what are the current treatment guidelines for managing asthma? And how do these guidelines help clinicians determine the most appropriate treatment strategies for different patient populations? And I'll caveat that by, again, explaining a lot of what we do on the other side is population-based. And we have prior auths and we do other utilization management, but they're, again, geared towards a population level. So it's often difficult to marry that up to a guideline, which are more geared towards individualization and appropriate treatments. So with that caveat, again, maybe restate the question is, what are the current treatment guidelines and how do they help you determine what is the appropriate choice of therapy for a specific patient?
So Jeff, there are multiple guidelines, and the two that I really pay attention to are the GINA guidelines, which are International Global Initiative for Asthma Guidelines. And then the other ones are the NHLBI, or the National Heart, Lung, and Blood Institute guidelines. The important part about these guidelines are that they play such an important role in guiding those of us who take care of patients with asthma, as well as patients, by providing us the best evidence-based recommendations for asthma management. So they help us in how to diagnose asthma, how to treat asthma the best way, and, literally support the best possible way that we can treat our asthmatics. What I do want to bring today to the discussion is that we've seen a tremendous change in how asthma is managed. We now have medications that we're going to talk about called biologics that potentially allow us very personalized treatment based on things called biomarkers, some of which we can check in clinic, for example, blood eosinophils. There is something called FeNO, or fractional exhaled nitric oxide, which tells us if someone has type 2, more allergic eosinophilic type of asthma, and IgE, the allergic antibody levels. So these guidelines are evidence-based treatment guidelines, and I think as a payer then, it probably helps you also in then deciding which of the medications the insurances should cover.
Fantastic. So kind of digging into that a little bit more. So for somebody who's listening to us today and may not be familiar with GINA, for example, and want to go look at it, are the guidelines granular enough to say if you have this biomarker or this eosinophil level, you should use this drug instead of this drug? Are they granular to that level?
So it's very easy for us to say, if you see this, then do this. But in real life, patients are complex. They have multiple comorbidities. There may be many things, including their financial status, that may play a role in us deciding which medication to recommend. But yes, these guidelines, I think, give healthcare workers enough of guidance as to suggest if your eosinophils are high, then consider this medication. If your FeNO, or the fractional axial nitric oxide I mentioned, is high, then this medication is likely to work better. So I do think they give us good guidance. How granular they are, you really have to put it in perspective of each patient.
Fantastic. Thank you. That's super helpful. Let me lob this over to you, Dr. Kobernick. So with a different hat on, how do you use clinical guidelines and how do payers use it? And how do they potentially influence coverage decision, resource allocation, or any other utilization strategy?
Great question. And part of the role of the payer is to do what I call clinical and logistical vetting of a particular medication or treatment. So from the clinical perspective, we're trying to understand and apply standard of care guidelines to the treatment protocols that are proposed by the treating physicians when they're selecting a complex medication. So medications, the guidelines help us assure the members and that they're getting care that's consistent with the standard of care, and that it also helps us select the medications so that they're in concert with the needs of the treating physicians. The challenge that health plans face is that, one of the many, is that there are, in the biologic space, there are several medications. And so that trying to decide which to use when, as more and more come to, are approved by the FDA and come on formulary, becomes a challenge for the health plans. Typically, any prior authorization criteria are formed by in concert with the FDA label, which really is generated from the inclusion criteria of the trial. So when there's a clinical trial to test a medication, certain individuals and certain pre-treatments are part of the selection criteria for the individuals in the trial. Those get applied. When guidelines emerge, particularly from the American College of Allergy or other well-known guideline areas, it really helps us with the evidence-based information we need to do our clinical vetting.
Thank you. Yeah, so to me, the way I would summarize this, keep me honest, is guidelines are a great starting point. They're becoming more robust. They identify high-level things that we should be looking at when we're making treatment decisions, such as eosinophils, IgE levels, but there's still somewhat of an art to it based on a lot of other factors that are introduced at the patient level. So then to your point, Dr. Kobernick, is then the challenge becomes, how do we translate population tools and PAs to something that fits, the individual patient. But it's a starting point, and there's good information there, and we should be looking at it and taking that into consideration when we're setting our coverage decisions. So that maybe use that as a springboard and kind of jump into some of the specific agents and where they fit, whether it's from a guideline perspective or a payer perspective, formulary perspective. So, Dr. Peters, do you mind maybe taking a stab at that? Just give us an overview of the agents, how they're differentiated, and any potential important pivotal trial data that we should be aware of.
Sure, I'd be happy to. So the thing that I would say right off the bat is that these biologics are targeted towards patients, some for severe asthma, some for moderate and severe asthma. The severe asthma group makes up about 5% of our total asthma population. But this is the group that tends to get hospitalized. This is the group that goes to the emergency rooms and urgent cares. This is the group that gets frequent courses of systemic corticosteroids, which we know have a lot of side effects. This is the group who has significant quality of life impairment. So we are very lucky that over the last 20 years or so, we have these biologics, and I'll just go through them as a class. One of the things to remember is that our biologics target mostly type 2 inflammation. One of the first ones that was approved for asthma, moderate severe asthma, was omalizumab, which targets IgE, the allergic antibody. And what omalizumab showed that in individuals with allergic asthma, and if you met their inclusion criteria, it improved symptoms. Patients did better, it decreased exacerbations. After that, for a while, we had nothing more new till mepolizumab was approved, I think around 2015. Mepolizumab, rosuzumab target IL-5. IL-5 is a molecule or a cytokine that is released in our body and is what I call the eosinophil growth and survival factor. It leads to eosinophilic asthma. Checking blood eosinophils is something that's very easy for all of us to do in medical practice. And studies have shown that if your blood eosinophils are high, potentially you have higher risk of asthma exacerbations. So these drugs like mepolizumab and rosuzumab have shown to reduce asthma exacerbations, improve symptoms. And this has been shown in our phase 3 trials like MENSA trial for mepolizumab, BREATHE trial for rosuzumab, but also now in real world studies. And mepolizumab has also shown in patients who are steroid-dependent asthmatics to reduce the systemic corticosteroid need while improving symptoms. Another drug that targets eosinophilic inflammation is benralizumab, which targets IL-5 receptor alpha and also is for eosinophilic asthma, severe asthma. It improves symptoms, reduces exacerbations. Dupilumab targets IL-4 and IL-13 signaling, and in studies such as QUEST, has shown to reduce exacerbations, improve lung function, reduce the need for systemic steroids, and benralizumab has shown that too. And then lastly, our newest biologic is a drug called tezepelumab, which targets TSLP. This drug shows benefit in people who have type 2 inflammation, those with elevated eosinophil, elevated FeNO we talked about earlier, but it is the only biologic that also shows some benefit in non-type 2 asthma. This is the group of asthmatics that don't have elevated eosinophils, don't have elevated FeNO. So the good part about these biologics are they decrease exacerbation, improve symptoms. How do you choose one? It's based on, as I mentioned, eosinophil levels, FeNO, IgE. And these drugs also, many of them have been approved for other comorbid conditions that go hand in hand with asthma. For example, chronic rhinosinusitis with nasal polyps is present in about 1/3 of severe asthmatics. Omalizumab, mepolizumab, and dupilumab are approved currently for chronic rhinosinusitis with nasal polyps. So if I had a patient who had both severe asthma and nasal polyps, I would potentially consider one of those. If I had someone with both type 2 and non-type 2, I would consider tezepelumab. So there are many things that help us decide. And if someone's eosinophils were really high, I would consider benralizumab, mepolizumab, or rosuzumab. I hope that gives you some idea of how I would consider choosing a biologic.
That's a fantastic overview, and it very much helps explain the nuances here between, again, eosinophils, IgE levels, things like that. So on what would lead you to choose a particular agent over another. So that was fantastic. Thank you. I want to ask you both a similar question here next, and I'll start with you, Dr. Kobernik. What would you say are the primary barriers to treatment for asthma that patients or providers face?
There's quite a few, and I think I'd highlight the educational understanding of the condition and its treatment, which has to do with the contributors and triggers. So for instance, the things in the home that contribute to and worsen asthma and allergies, things like dust, pets, smoking, all those things that occur in the home that I think people really struggle with understanding. I think access to care for individuals of limited means is another struggle. And I'm very cognizant of the fact that just because someone has health insurance doesn't mean they can afford health care. There's lots of people who are in lower salary bands, for instance, that really struggle with paying out-of-pocket expenses and are making choices around the medication out-of-pocket expenses versus gasoline and food. So I think that that concept of the social determinants of health are a big barrier that people experience. I think coupled with that is understanding how to take their medication. That leads to poor medication adherence. And I think that using the inhalers can be complex for people, particularly if it's a corticosteroid and there's a unique route of administration, if there's a spacer, if there's some other things that make it more complicated to use it correctly. I think really people struggle with that. And as a result, they're not able to maximize the therapies that are offered. And finally, I think that the medication regimens themselves are complicated. And so they really need extra education and extra support, which really leads to a broader problem in healthcare and individuals with chronic disease, which is care fragmentation. That is that they might be seeing a variety of doctors people might be going to the emergency room and getting care. And then they might be going to their primary care doctor and getting care. They're going to the corner urgent care. And what we find in those settings that there's trouble in communicating across the different settings. And so individuals might be exposed to several treatment approaches. So this concept of care fragmentation is really challenging. And sometimes we've seen, like our plan has care managers that work as a continuous person in their care. I know a lot of the allergists in their office, like Dr. Peters, really work hard to coordinate the care of these patients. But I think that really that illustrates several of the problems and barriers that our patients are facing.
Yeah, great overview. And I would just say, I think even as providers and, me being a pharmacist, going back to what Dr. Peters introduced, there's a lot going on here with, again, MOA and eosinophils and different things, just trying to wade through this. Even as somebody who's in this all the time, it's still complicated. And unfortunately, the people who are at greatest risk are probably the people that you mentioned to have potential, educational needs or access issues or other things, which is a conundrum.
Right. And if it's complicated for us,
right.
Imagine, I think that's part of your point. Imagine how difficult it is for someone without the training that we have.
Exactly. Again, thank you for that. Dr. Peters, do you have anything to add to Dr. Kobernick's comments?
I think Dr. Kobernick really explained it well. These are complex patients with multiple, often comorbidities. The asthma is a chronic disease, and sometimes patients, don't want to take medicines either. They're afraid of the side effects, whether they may be real side effects or not. Costs obviously is something that comes up, especially with biologics, and that they have to be on these meds for sometimes many years. So, and even if insurance covers the costs, co-pays add up. When you're on multiple medications, even if the copay is $25, $50 a month, it'll add up. And then finally, these are complex patients. And if you're taking your primary care provider, you're in charge of many conditions, and you may not have the time or the expertise to focus on a patient's severe asthma if they also have coexistent diabetes, heart disease, hypertension, etc.
Perfect. And I want to come back to that here in a second and kind of talk a little bit about the roles and everything else. But I want to maybe step on my soapbox for a second and just say, I think I would like to see more of de-siloing and shared decision making and shared risk and everything else, because if we continue to work in our silos, we're probably not going to help with all of the issues that are going on in healthcare. So there's kind of my soapbox. And I love the comment that just because somebody has insurance doesn't mean that these things are easily explained or affordable or there's good access. So we need to continue to make sure that the right patient gets the right drug at the right time.
Yeah.
So, Dr. Peters, let me ask you this, and I also maybe will come back and ask Dr. Kobernick this as well. But from your perspective as a provider, what have you seen, or what would you like to see payers or managed care organizations do differently or better to help address these barriers to make your job easier and make it better for your patients?
I have to say what you just said, and I want to somehow record it, that have these drugs available for the right patient at the right time. And what was the other right you said?
Right patient, right time,
right
right.
drug, right patient, right time.
Yeah.
Yeah, I just think that's the bottom line. These are expensive drugs. We shouldn't be using them on a patient unless the patient really, we shouldn't be prescribing them to a patient unless the patient really needs it. And we should use the right medication and we should have the expertise on it. And I think this is where I hope, and most managed care payer groups do provide the medication. Sometimes it takes us a while to get them, and that can be frustrating in a busy day when we're seeing patients and doing notes, etc., and having to wait and make multiple phone calls to get a drug authorized. It's very frustrating and to have that restriction, but I also understand why that is, so that we use the right drug for the right patient at the right time. I think as we have good evidence-based criteria and pathways, and we all work together, I hope we keep moving towards the right direction.
I would argue, stepping through an inhaler controller med, or again, looking for eosinophil levels or something like that's probably not inappropriate. But are there barriers out there that could be better addressed?
I do think that some of the requirements, like you said, eosinophil levels, inhalers and stuff are okay. However, sometimes, and I'll just give you an example, for patients with severe asthma who have chronic rhinosinusitis with nasal polyps, there are biologics that work for both of them. However, it may be that it might be easier to get it if you put an indication, primary diagnosis as polyps versus asthma. Or someone may say they want it for their polyp patients and put the diagnosis asthma because that's easier. I don't think we should have to do any of that. And then the other thing, if someone has severe asthma, it's important to note that this is something that they will have for a long period of their life or potentially their whole life. And so side effects from things like systemic steroids are quite terrible, and people get their steroids all over. They may go to urgent care, they may go to multiple different doctors. And sometimes when insurances say, oh, you have to have had this many courses of steroids, I'm like, we can't always find that documentation, but we know the patient has taken it. They've told us that. So those are like hurdles that I don't like. But I also, if I have to say, most often when I see these drugs prescribed by my colleagues, they are prescribed for the right person for the right indication.
Fair enough.
I think you make a good point, which is sometimes we see a lot of inconsistency in prescribing going from the primary care setting to the specialty setting. I think you make a really good point there. And that's why these more complex medications that you're describing are best prescribed by the specialist.
I agree with that. And I also feel that, and I think this is something that we'll probably discuss, that these patients have many comorbidities. And if we can use one medication to target their underlying type 2 inflammation that could cover multiple diseases, that makes a lot of sense. That means you need experts in their specific areas. And I do feel that multidisciplinary care is really important. I'm really lucky I'm at an institution where I have these experts. And the best part about that is then the patient gets as much evidence and information and is informed before they make the decision also, because we always believe, as you said, Jeff, in shared decision making.
Perfect. So as promised, I want to come back to that because I want to spend a few minutes talking about the care coordination and how we can all play a supportive role in that. But let me go back to you, Dr. Kobernick, and kind of follow up a little bit. So, you wear a variety of hats, right? You're on both sides of this. So let me ask the same question that Dr. Peters addressed is, let's say from a provider perspective, what would you like to see managed care organizations do? And then with your payer hat on, what have you seen that's been successful? And do you have any other ideas on things that we could do to be better?
Yeah, I guess I'm going to work at your last question first, which is what do I think could be better? I think we need a better approach to fragmentation. We need a team-based approach that helps people address all the complexities of their illness. And what we know when we think about chronic disease, and asthma is an ideal disease to talk about in this context, is that there are a variety of variables that impact the outcome. And no one physician themselves, whether it's a primary care physician or a allergist immunologist, can attend to all those needs. We know that our asthmatics have the depression of chronic disease, so they need behavioral health support. We know that many are impacted by the social determinants of health, so they can't afford care or they can't have they don't have transportation. We need somebody on the team to address their logistics. And we know that they have primary care service needs. So we need somebody to work with them on prevention and getting the appropriate vaccines and screenings. And to expect one office, one physician to do all of these things is really an unrealistic expectation, I think. And so what we can do differently and better is use a team-based approach where you have in the setting, you have the appropriate members of the team to support the patient. And so it's nutritionists, social workers, psychologists, all the individuals that will impact all the things that we're talking about. So I think we can do that better. And I think we can, as a payer, figure out ways to pay for it in a more comprehensive way. And that gets you to this conversation, probably best held in another session on value-based care models. And a lot of the work I do at the Jefferson College of Population Health, where I teach, is on new models of care. But I think we need, as a community, to take a community approach to the management of these patients. And I think that would lead us to address the most annoying aspect that the providers face, which is the prior authorization process. It's as administratively streamlined as it can be. It varies from payer to payer. However, its goal is to make sure that the medications that are selected are being appropriately given. In a value-based model, you could see no prior authorizations because you have such a strong relationship with the care team, and that the decisions that were made were always being made on behalf of the patient. So that could be part of the concept behind that. So I guess where we are today is not where we have to stay in the management of asthma and other chronic diseases. And I think that there's a tremendous opportunity for us to develop some of these care models. Not sure if I answered your questions, but
Yeah, I think you did.
I think I got close.
Yeah, those are all great comments, and I'm glad. So I'll kind of go back and summarize a couple things because I'm glad you mentioned several of them. The first is prior authorization. So, we need to make sure our prior authorizations are appropriate and not overly egregious. And then you both kind of talked about it is the role of the specialist. And so I would argue that, once a patient gets to a specialist level, then there ought to be a little bit more leeway on the PA than being hard, fast and black and white on, hardcore on the PA. I love this concept of, value-based arrangements and things like that. It goes back to, again, my soapbox of shared risk. And it would be, probably don't have time to address it today in more detail, but maybe that's a subsequent conversation. So, again, it's breaking down silos, it's sharing risk. And if we don't do that, again, the healthcare system's so fragmented, it's going to be hard to navigate. Because, the only other thing I'll mention here is that we haven't really touched on is what's going on around affordability at the health plan employer level, there's a lot of struggling and frustration going on just in terms of, drug trend, not pointing fingers.
Yeah.
But the challenge is if you follow the dollar, that ends up at that level, and then that gets translated back to our patients. And that's the problem. So to your point earlier is, somebody might have insurance, but if they're in a high deductible or co-insurance or something like that, these things can often be out of reach, even if they are prescribed. So let's dive into this. Maybe it's kind of our wrap-up topic here, and that is, what we've all been dancing around, which is multidisciplinary care teams and how we approach this and collaborate. And I think there's probably different viewpoints based on how we're coming from this. And so I'm let me start with you again, Dr. Peters, on how you coordinate from a provider perspective and how you pull in, other colleagues and other things to address the complicated nature of these patients. And then maybe Dr. Kobernick and myself can kind of tag team a little bit more, I think, on what the role of the payer is in that.
Sure. I have to say that as a specialist who understands inflammatory pathway and what is going on, the underlying type 2 inflammation, I do feel like I know when a patient needs other specialists to manage some of their other complex conditions. So again, having those experts available in the healthcare system is so important. They are also expensive. So this is where I do think the payer is important. So for me to send a patient to, for example, a gastroenterologist and have them get a scope to look to see if they have a comorbidity called EOE, which may occur in patients with asthma, that means endoscopy, and that means it's expensive. So I do think those parts, hopefully payers understand. And I do think this is where also what Dr. Kobernick mentioned, that these are complex drugs, these are complex patients, and it probably is not a primary care physician who should be prescribing these biologics. It should be a specialist, someone like an allergist or pulmonologist, an ENT or GI. But I do think allergists are kind of in the central part because they understand all of this information. And having the specialist gives the patient the best care then, because I can then say, yep, you have this other comorbidity, go see the specialist for this. And maybe we can treat both your conditions with a biologic, but maybe you need surgery. Is that kind of?
Yeah, that's great. Yeah, I'm kind of curious if limiting access to these medications to specialists kind of across the board, does that actually create more of an access issue?
I'm not 100% sure. I would say that create a barrier. I do think there are places, and this is where telemedicine is amazing. So something good that came out of COVID. So there are parts of the country, including parts of Chicago, where getting a specialist may be difficult. But I do think if we had some pathways where potentially a primary care physician could work with a specialist, maybe the specialist just see a patient on telemedicine and help the primary care, then potentially a primary care physician could prescribe some of these drugs. I just think that these are expensive drugs, complex patients. So you want to make sure the right patient gets the right drug at the right time.
That's a great call out. Telemedicine, which is probably falls somewhat under population health, maybe social determinants of health, things that we can do to address that type of issue. So I'm glad you called that out. That does potentially address some access issues. I think going back to prior authorizations, I think as we build more AI into that and, make that more efficient as well. So it's less manual. That also probably helps. So there's a lot of things that are, I think there's a lot of things that are scary moving forward, but there's also some things that we can leverage to make this better. So Dr. Kobernick, how about you? How would you answer that question? The role of multidisciplinary care teams in that, coming from your perspective?
Yeah, I think we teased at that as I was talking about team-based care. And I kind of, because of the complexity, I like to say that it takes a team, similar to the conversations we always have with it takes a village. What we do at our plan is we have a care management team. They're regional teams. They're scattered across the country. They're multidisciplinary. Each team is anchored by a nurse who is the primary contact point with the member. And on the team are a variety of disciplines. Pharmacy's there to do medication reconciliation and education. Social work's there to assist with behavioral health issues and logistical issues. Someone's there to help with transportation and so on. So that the care management programs for complex illness have evolved to fill this gap that's occurring at the care sites. We are seeing in different leading conditions, I call them, multidisciplinary care approaches. So there's literature on the hemodialysis medical home, for instance, where all of the care is provided through the hemodialysis center, including the primary care services. And we're seeing the success in Medicare Advantage of team-based clinics like Oak Street, ChenMed, and the like. They're successful because they're team-based. And so the physician does the proportion of the work, but the rest of the team does the other kinds of coordination and comprehensive care that's necessary. I think that the collaborative model for chronic disease is where we're headed. I think the payment models will be, as you described, the shared risk payment models will fit nicely with that. And I do think we'll see more and more of that as we move forward, in 28, 29, 2030. I think we'll see a lot of team-based approaches.
Fantastic. And I wholeheartedly agree with what you've both been saying here and wholeheartedly support better models on the payer side. And I talk to colleagues all the time, through care management, disease management,
Mm-hmm.
and having nurses, pharmacists, social workers working together. I do think there's an opportunity here. And I think payers they have an obligation here. So we have data that maybe not everyone else has. We know if they are refilling their medications, we know what other diagnoses they have, all of this. So I think we potentially have the role to be the quarterback here and to help. But as we do this, it has to be in collaboration with the physician because for obvious reasons, but also what we've seen is that going back to what we talked about earlier, this is so complicated that if a patient is in the middle of this and they're trying to figure this out and they're getting calls from especially pharmacy, the payer, the nurse, the physician, it's very confusing. It actually probably makes the confusion worse and it's frustrating. So to me, one of the take homes in listening to the two of you just reiterates the fact that we need to figure out how we collaborate better together and find better seamless solutions that are patient-based so that we can drive outcomes and lower costs. So we are about out of time. I'm going to ask one last question, and then we'll dive into the questions. And Dr. Peters, I'm going to ask you the question. Most of the people that are probably listening to us right now are payers. So as a specialist in this area, a content leader, what would you say to payers that would help the delivery of care for at-risk populations?
So what I would say is that these patients are, as we've talked about, complex. Their quality of life is really affected. Their day-to-day life is affected. Their work is affected. They're taking, enjoyment of life is affected. If you're short of breath, you're coughing, you're wheezing, you're waking up in the middle of the night. Often you have other comorbidities such as eczema, polyps, hay fever. That can all influence your quality of life poorly. You end up taking systemic steroids quite often. Sometimes people with asthma. So this is a serious condition. It's a very common condition. We have for a long time had inhaled steroids, long-acting beta agonists, and systemic corticosteroids. We are lucky now we have biologics. We can change the lives of our patients positively. So I think it's really important, as you've mentioned, that we get the best care for our patients. I think it's the responsibility of workers to choose the right medication based on the best evidence we have. And I think it's the responsibility of the payers to let us treat our patients with the right medication, as long as we're doing it the right way, so that we can get these medications without too much of a hassle.
Fantastic. Thank you for that summary. That was perfect. So at this time, we would like to address some of the audience questions that have come in. Let's jump in. Dr. Peters, I am going to direct this first question to you. And given the MOAs that you discussed and the role of the different interleukins, is it ever recommended to prescribe more than one agent to target more than one interleukin?
That's actually a really good question. We've had these biologics for a while to treat severe asthma, and we know some of these biologics also treat other conditions, but these are really expensive drugs. So if I have to choose a biologic and someone has more than one condition, I'll try and choose one which will treat both of those conditions or multiple ones of those conditions because they're often comorbid. In a rare case, though, we may use two biologics. And the one that I will tell you is the only one when I do it is something called EGPA, which is something that happens in those with severe asthma, nasal polyps, sinusitis, and it can cause life-threatening disease with affecting the heart, the kidney, the gut, the brain, any which number of things. These patients, I will give them what we call anti-IL-5 agents that are approved for EGPA. But some of these people will then have very severe sinus symptoms, and then I might give them dupilumab to target, which is the anti-IL-4 receptor antagonist. But again, I do this a lot, and I have maybe 3 or 4 patients who are in more than one biologic from me.
Perfect. Thank you. There's another comment that was submitted. I think it's more of a comment than a question, but I think it's a good comment, so I want to address it. And I'll just read it. It says, not all specialists are created equally. And so having all specialty bypass the PA process assumes they are. And in my opinion, it's not truly appropriate. I think that's right. I would agree with that statement. I don't, if, maybe we misspoke. I don't think I would advocate for not prior authing medications that are expensive, but rather than allow all specialists, I think this is where we can talk about gold carding. And a lot of it goes back to how we identify and work with specific specialists. And if there's a comfort level there and we're confident that both sides are working towards the same goal, then that would be a better way to do it rather than just removing that from the PA process itself.
I completely agree with you. I don't think all specialists should be able to bypass prior auth. These are crazy expensive drugs. In the special, even within my field, I would say I actually think not all should ever be bypassing, but some that use it judiciously and use it for right people should.
Perfect. Yeah, we had a couple questions come in that I think are more geared towards me, so I'll start with those. So there was a question about whether or not I have an example of how we've used health plan or claims data to make more informed coverage policies or decisions for patients with asthma. That is a great question. And this is one I struggle with all the time and I think it's an offshoot of real world evidence as an example, is how we use data to make decisions, which can include formative decisions or case-by-case prior authorization decisions. And I struggle with RWE or real world evidence. And we don't use that, honestly, when we're setting formularies or setting PA criteria, I don't think. That really comes from the clinical trials and what the package inserts say. But claims data itself is super important, and it plays more of a role in how we manage care management and disease management. So we use that all of the time. So we have medical data and pharmacy data for all of our members, and we should be using that when we are managing patients case by case, which should be the case here. If somebody is on an expensive medication and having exacerbations, for example, and goes to the ER hospital, they should be care managed. So I think that is where I would say the best role of health plan or claims data is more care management, disease management than formulary. So I think maybe we can both chime into this next question. I'll ask you first, Dr. Peters, and then I'll chime in. And we kind of addressed that at the end of the formal presentation section, but where in the patient journey do you see the biggest opportunity for payers to make a difference? How would you answer that from a provider perspective?
As a provider, in terms of patient journeys, I think there are multiple places that difference can be made. For now, we definitely know that the severe asthma, which is about 3 to 5% of asthmatics, are who get admitted to the hospital, who are sometimes will have, are at risk even of dying of asthma. So I do think that's where these individuals should get biologics if they qualify for it. So I think that's where a big difference can be made. However, if research over time shows us that maybe early introduction of these biologics would be beneficial, in that if you introduce it early in the right person, you could prevent, irreversible lung damage, then maybe we even think of it earlier. But based on current evidence, I would say it's those severe or some moderate asthmatics that I think should be treated with these biologics. These are crazy expensive drugs. So we need to be very, very careful with it.
Thank you for that comment. And I would say, with my payer hat on, I think we can participate really throughout the entire spectrum, but we're not screeners, we're not prescribers. So, but once that claim hits and once we know who the patient is, then we can definitely intervene, because we have all the data. So we know what the patient is doing, what they're not doing, if they're compliant, what other medications they're taking, what other comorbidities they have. And I think we do have the responsibility to act as an advocate and to manage these patients. Having said that, maybe I'll renege a little bit on my last comment that, we're not necessarily prescribers. I think we also could look at gaps in care and other issues. And so if somebody is not taking a medication, or even if they are and they're in the ER, then we could look at gaps. So, let's say they're taking an inhaler and they should be on a biologic, and because they're in the ER a lot, that might be an opportunity for us to intervene and work with the provider to better manage these patients. So again, I'm biased, obviously, because I'm a payer, but I think, we can really intervene across the entire spectrum, and it is an opportunity. And just to reiterate, it's because we have more data than most people. So that's an advantage, and if we can use that appropriately, I think it's a good thing. But like we said, as we wrapped up, the key there is coordination. Yeah. So whatever we do has to be in coordination with the specialist or the provider. And one is because it delivers better care, but also it's better for the patient, and it's less confusing, it's less irritating, because I would imagine the last thing that a patient wants is to hear from their doctor and the nurse and the specialty pharmacy and the payer and the PBM. So coordination, to be repetitive, is super important.
I have to completely agree with you. I think best place right now is where we have the best evidence. And if the data supports the evidence we have, that's great. I will tell you, patients often get more frustrated at us. I don't know. I don't see how frustrated they get with you all, but they seem to think that sometimes when things are not approved, it's because we either are not doing our job correctly, or that we just are not doing it correctly because we're not getting them the drug.
And that's a great point. The healthcare system is complicated, even for people like us.
Yeah.
So to a patient, it's extremely complicated. It can be confusing and frustrating. And so that's just it. I'll just say, most of the time when a prior auth is denied, it's because there's just lack of information. It's not because we're trying to deny it on purpose. So despite what maybe some of the perceptions are around, payers and PAs, it really comes down to the right drug at the right patient, to your point. And, if it's earlier on and we can prevent things, that's great. But it really is right patient, right drug, right time. And so that coordination is super important. There was a similar question. I think we answered this, but I'll just see, Dr. Peters, if you have any other comments. And that is, how can a PBM better support multidisciplinary care for patients with more severe asthma? Again, I think we talked about that is communication, it's data, it's appropriate intervention and communication, and it's working in collaboration with the provider. So I don't know if you have any last comments about any suggestions or comments to our payers who are listening to us today.
I think collaboration is key, but one other thing I will ask you, some of these people who have severe asthma have other comorbidities, need multiple healthcare providers. There are models where two healthcare providers will see the patient at one time. So for example, I do a joint clinic with the ENT and see many of these patients because they have severe asthma and nasal polyps. Then to provide, so that if the payers can pay then the providers for their visit at the same time, which I think sometimes becomes a little bit difficult how you code it and stuff. That is very helpful, would be helpful. But I think, you like you said, collaboration, us providing the data that this medicine is necessary, and we do it for the right patient.
Perfect. Thank you. No, that's a great comment. I think I'll just wrap up and just say, the title of this was Best Practices in Moderate to Severe Asthma Management. So we have great drugs and we have the obligation to manage our patients. There's good ways to do that. There's not so good ways to do that. So we should be looking at our data and focusing on gaps in care, focusing on compliance, focusing on outcomes, but do that in a clear, collaborative way that does not frustrate the patient. So I would now like to conclude the webcast. Dr. Peters, thank you very much for your presentation and for your comments and for being here. I would also like to thank Dr. Kobernick. But I also lastly, once again, would like to thank Regeneron Pharmaceuticals Incorporated and Sanofi for their support of this educational activity. And this concludes today's webcast. One last plug, don't miss the live webcasts that are coming soon on the last topic of this series, which is on COPD. And to participate in all the type 2 inflammation CE, including podcasts and infographics, please visit www.impactedu.net/T2-inflammation. So hopefully you enjoyed the presentations today, and we appreciate you joining us, and enjoy the rest of your day.